Hello. Good evening, everyone. Dr. Krishna Garg, we welcome you to the Radguru e-learning program. Dr. Krishna Garg is ex-professor and head Department of Anatomy, Lady Hardinge Medical College, New Delhi. She has revised and edited 4th and 5th editions of the popular B.D. Chaurasia's Human Anatomy. She is co-author of Anatomy and Physiology for Nurses and Allied Health Sciences. She was awarded Satyapal Sabharwal Award for contribution to IHMC Alumni Association 2009 and Chikitsa Ratan Award by Delhi Medical Association 2010. A warm welcome you to our Radguru program. So over to you, Doctor.
Thank you. Good afternoon. Today we will start with the discussion of the brachial plexus, and it will give you all people nostalgia for what you studied about 7 to 10 years back. The brachial plexus comprises of two words, brachial and plexus. The brachium is a Latin word which means the upper limb, so that the brachial plexus will have supply to the muscles, skin, joints, and blood vessels of the whole upper limb. And plexus means an interchange of nerves, which is a complex interchange of branches. So that means the plexus is an overlapping of the myotomes and dermatomes. If there is one segment of the spinal cord is injured, the brachial plexus, the muscle will not get paralyzed. It will be weak. So that this is an overlapping of the myotomes and overlapping of the dermatomes. The brachial plexus is formed by the ventral primary rami (VPR) of cervical 5, 6, cervical 7, 8, and T1 segments of the spinal cord. The ventral primary rami of C4 and T2 give a very small contribution. So normally it is formed by C5 to C8 cervical segments and T1 thoracic segment. Of a spinal nerve. This is a segment of thoracic, one segment of the spinal cord. It has a dorsal horn which is narrow, a lateral horn, and a anterior horn. Anterior horn fibers are motor. In the posterior horn, the sensory fibers are entering. So the nerve is a mixture of dorsal root and a ventral root, and this trunk divides into a dorsal primary ramus which is smaller and a ventral primary ramus which is bigger. In T1 to L2 segments of the spinal cord, there is an additional lateral horn which is known as the thoracolumbar outflow and gives sympathetic fibers to these nerve roots. In this particular diagram, these fibers are shown by red color. They enter the ventral root and the trunk, and from the beginning of the trunk there is a white ramus communicans which goes to sympathetic ganglia. Some of these fibers, they relay in the sympathetic ganglia and pass as postganglionic fiber via the gray ramus communicans, and these fibers go both to the ventral primary ramus and the dorsal primary ramus. So now the ventral primary ramus contains three types of fibers. Green ones are the sensory fibers, the red dotted ones are the postganglionic sympathetic fibers, and the black ones are the motor fibers. These particular fibers are seen in T1 segment of the spinal cord, and they supply the T1 spinal nerve. How do the fibers to cervical 5, 6, 7, 8 cervical nerves reach? These particular fibers arise from T1, T2, T3, and T4 segments of the spinal cord. They ascend up in the they ascend up in the sympathetic chain and reach the middle cervical ganglia and the inferior cervical ganglia. From the middle cervical ganglia, the fibers relay and go to spinal nerve C5 and C6. From the inferior cervical ganglia, the fibers which relay go to C7 and C8 spinal nerves, so that all the nerves C5, C6, C7, C8 and T1 manage the postganglionic sympathetic fibers. Some fibers even reach the superior cervical ganglia and they give postganglionic sympathetic fibers to C1 nerve, C2, C3 and C4 nerves. Besides giving these fibers to the spinal nerves, they give fibers to the external carotid artery, a common carotid artery, to the inferior thyroid artery, to the thyroid gland, pharynx, and they even give branches to the heart. So that now the spinal nerve has got sympathetic fiber, sensory fiber, and the motor fiber. The formation of the brachial plexus. This is the very important component. The brachial plexus is made up of roots, trunks, divisions, cords, and branches. I will be only confining myself to roots, trunks, divisions, and cords. The roots or the rami are formed by C5, C6, C7, C8, and T1 segments of the spinal cord. These roots or rami of C5 and C6 join to form the upper trunk of brachial plexus. C7 remains single and forms the middle trunk of brachial plexus. C8 and T1 join together to form the lower trunk of brachial plexus. These are shown in orange color. Each of these trunks divides into a division, all shown in green color. 3 divisions are ventral division and 3 divisions are dorsal divisions. These dorsal divisions of the upper trunk, middle trunk, and lower trunk join to form the thick posterior cord of brachial plexus. The ventral division of upper trunk and middle trunk join to form the lateral cord of brachial plexus, and the ventral division of the lower trunk remains solo to form the lower trunk of brachial plexus. So we have, out of 6 divisions, we have 3 cords: lateral cord and medial cord, which supplies the anterior aspect of the limb, and the posterior cord, which is thicker, which supplies the posterior aspect of the limb and posterior aspect of the muscles of the upper limb. Some fibers of lateral cord, they give a communicating branch to the ulnar nerve, and this particular communicating branch carries the C7 fibers. So that ulnar nerve carries fibers of C7 segment, C8 segment, and thoracic 1 segment. This is the formation of roots, trunks, divisions, and cords. The roots and trunks lie in the supraclavicular part of the neck. The divisions lie behind the clavicle or retroclavicular part, and the cords and branches are lying in the infraclavicular part and in the axilla. The branches are there from the roots and trunk. From the roots, the branches are for the muscles of the prevertebral region, longus colli and longus capitis, etc. One important branch is to branch to phrenic nerve. This phrenic nerve is mainly formed by C4 segment, but C5 gives a small root to the phrenic nerve, and phrenic nerve is the one which supplies the respective side of the most important muscle of the respiration, that is the thoraco-abdominal diaphragm. Another nerve which arises from the root is the dorsal scapular nerve. This dorsal scapular nerve supplies the rhomboideus minor and rhomboideus major muscles. These muscles are arising from the spines of the vertebra and get inserted into the medial border of the scapula, and these are retractors of the scapula. The other nerve is the long thoracic nerve. This arises from C5, C6 and C7 roots, and it is lying on the surface of the serratus anterior muscle. That is why it is known as long thoracic nerve or nerve to serratus anterior. This particular muscle is a protractor of the scapula, and it also helps in overhead abduction of the shoulder joint from 90 to 180 degrees, so that both the retractors and protractors are supplied by nerves which arise from the roots of the brachial plexus. Now coming to the trunk, only the upper trunk gives branches. One nerve is the suprascapular nerve, which supplies the supraspinatus and the infraspinatus muscle. The supraspinatus muscle helps in the abduction, 0 to 90 degree of abduction of the shoulder joint. The nerve to subclavius is the one which supplies the subclavius muscle, and subclavius muscle acts as a cushion for the artery and cords of brachial plexus to go down behind the clavicle into the axilla. This nerve to subclavius sometimes may give a branch even to the phrenic nerve. So these are the branches of the roots and trunk of brachial plexus. The other branches from the cords are parts of the nerves which can be taken up at a later stage. Some of the relations of the trunks, the C8 ventral ramus of C8 and ventral ramus of T1 thoracic 1 nerve form the lower trunk of brachial plexus, and it lies in a groove on the upper surface of the first rib. The first rib is placed horizontally, and it has an inner border and an outer border, a tubercle for the insertion of scalenus anterior muscle. Behind that is a groove for subclavian artery and the lower trunk of brachial plexus, and in front is a smaller groove for the subclavian vein. In relation to the neck of the first rib, from medial to lateral side is the sympathetic chain, posterior intercostal vein, superior intercostal artery, and the lower trunk of brachial plexus. So the mnemonic is chain pulling upon a vein, artery, and a nerve. Here the relations of the trunks are shown in the posterior triangle of neck. Posterior triangle floor is formed by scalenus medius, levator scapulae, and the splenius capitis, and the muscle which is lying behind the sternocleidomastoid is scalenus anterior. So the brachial plexus, the roots and trunks of brachial plexus lie in between scalenus anterior and scalenus medius. Medius is posterior and scalenus anterior is anterior. And related to these are the subclavian artery, which is lying behind the scalenus anterior muscle, and scalenus anterior divides this artery into 3 parts. First part medial to the muscle, second part behind the muscle, and third part lateral to the muscle. Subclavian vein, of course, cannot bear the pressure or pull of the scalenus anterior muscle, so it is not lying under cover of the scalenus anterior muscle. This is the scalenus anterior and scalenus medius. Part of this is supraclavicular, part is retroclavicular, and the lower part is the intraclavicular part of brachial plexus. Here is the diagram showing the posterior triangle, the part which is not related to the brachial plexus, but of course is very important in relation to the posterior triangle, is the cervical lymph nodes around the very important accessory nerve. This accessory nerve supplies the sternocleidomastoid, passes through the posterior triangle and ends up in the trapezius muscle. This is diversifying myself, but in the lower part you can see the transverse cervical artery and the suprascapular arteries. These are the arteries which are branches of the thyrocervical trunk from first part of the subclavian artery, and thyrocervical trunk is the one which supplies the roots and trunks divisions of the brachial plexus, and this thyrocervical trunk is a lifeline to the brachial plexus. The C8, the C7 and C8 rami of the brachial plexus are the largest. C5 and T1 are the smallest. Motor fibers are seen maximum in C5 and C8 segments. Sensory fibers are maximum in C7 segment. The posterior division of upper trunk and middle trunk are largest, whereas posterior division of lower trunk are smallest. The adult brachial plexus contains 120,000 to 150,000 of myelinated fibers. These I have recently taken from the 41st edition of the Gray's Anatomy. The blood supply of thyrocervical trunk, blood supply of brachial plexus is the thyrocervical trunk, which acts as a lifeline to the brachial plexus. The relations of the cords of brachial plexus to the axillary artery, one can see in this diagram that vein is medial and artery is lateral. This is showing the first part of the axillary artery, which is lying medial to the pectoralis minor muscle. The lateral cord and posterior cord lie lateral to it, lateral to the axillary artery, whereas the medial cord is lying posterior to the axillary artery. They are not lying according to the names. And here we can see the clavipectoral fascia. Pectoral fascia is pierced by three structures: one vein, the cephalic vein, one artery, the thoracoacromial artery, and one nerve, the lateral pectoral nerve. These are the relations of the three cords of brachial plexus to the first part of the axillary artery. In the second part of axillary artery, the names of the cords are related according to its relations. The lateral cord is lateral to the artery, the posterior cord, which is thickest, is posterior to the artery, and medial cord is medial to the artery, between the axillary artery and the axillary vein. These are the relations of second part. In the third part of axillary artery is not related to the cord, but is related to the branches. So I have skipped that part because branches will be done separately. So the mnemonic for the brachial plexus is Ramu, Taylor, drinks, cold, beer. Ramu, R is for roots or rami. Taylor is for trunk. Three trunks, upper, middle and lower. Drinks, D is for divisions, 3 ventral divisions and 3 dorsal divisions. And cold, C is for cords, the lateral cord, medial cord. These two cords supply the front of the upper limb, and the posterior cord, which is thickest, supply the back of the upper limb. Peer is for branches, which will be taken up at a later stage. Now we come to the applied aspect of the brachial plexus, the ERB'S point, or which causes the ERB'S Duchenne paralysis. C5 and C6 segments, they give rise to the two roots of brachial plexus, and they form the upper trunk. From the upper trunk arises two nerves. One is the suprascapular nerve supplying the supraspinatus and infraspinatus muscle, and going below is the nerve to subclavius. In addition, the trunk gives rise to an anterior division and a posterior division. This particular area is known as the ERB'S point. An injury to this ERB'S point is a very typical paralysis. Injury to this ERB'S paralysis or ERB'S Duchenne paralysis is a birth injury when the head is pulled tough, or when there is a forceps paralysis, forceps injury, forceps delivery, there is pulling of the head and neck, and the neck, the upper trunk of the brachial plexus may be injured. This is one way, or second way, there may be fall on the shoulder. Since 5 and C6 segments of the brachial plexus are involved, there is loss of sensation on the lateral side of the upper limb, both in the arm and the forearm. And the position of the limb is the upper limb is adducted and medially rotated. The elbow is extended. The wrist is flexed. The interphalangeal joints are flexed. It looks as if a policeman is taking a tip. Why a policeman? Why not a politician also? Everybody is entitled to take a tip. This is the KLUMPKE'S paralysis, where cervical 8 and T1 segments of the spinal cord are injured. There is undue abduction of the upper limb. It may be a birth injury or it may be a fall. And if a person falls down and clutches onto a branch of a tree, there is undue abduction that gives rise to paralysis of C8 and T1 segments of the spinal cord. In this, both parts of the ulnar nerve and median nerve are affected. There is hyperextension of the MP, metacarpophalangeal joint, and hyperflexion of the proximal and distal interphalangeal joint. So the hand looks in the shape of a claw hand. This is the position of a claw hand. The metacarpophalangeal joints are hyperextended, and the proximal and distal interphalangeal joints are hyperflexed. In some cases, if the injury is proximal to the white ramus communicans, there may be injury to the preganglionic fibers coming from sympathetic T1 segment of the spinal cord, which leads to a syndrome which is known as HORNER'S syndrome. HORNER'S syndrome comprises 4 entities. One is ptosis. In ptosis, there is partial paralysis of an important muscle, the levator palpebrae superioris. The second is there is constriction of the pupil because the dilator pupillae, which is supplied by sympathetic, get paralyzed. Third is there is enophthalmos. The eye seems to get sunk into the orbit because of the paralysis of an orbitalis muscle. And fourth, there is anhydrosis because of loss of sympathetic fibers. Sympathetic fibers are innervated, or the sympathetic glands are innervated by the sympathetic fibers. If sympathetic is lost, there is loss of sweating. So these are the 4 components of the HORNER'S syndrome. The other anomalies are the prefixed brachial plexus. Normally, the brachial plexus is formed by ventral primary rami of C5, C6, C7, C8 and T1 segments. In a prefixed brachial plexus, the C4 segment takes more important part, and T2 segment, thoracic 2 segment, does not take any part. In this case, the C4, since it is supplying the diaphragm, there is some reorientation of the nerve supply of the muscles of the upper limb. The another variation is the post-fixed brachial plexus. In this case, the C4 refuses to take any part in the formation of brachial plexus. C5 has a small contribution. C6, C7, C8 are normal, but T1 takes over, and T1 has a big contribution, and T2, though it was not giving any contribution in the normal brachial plexus, in this post-fixed brachial plexus, it has a contribution. So this T2 nerve may get pressed by the first rib, and there may be weakness of some of the muscles, intrinsic muscles of the hand. Now we come to the cervical rib. Cervical rib is not normally present. This is present in 0.5% of cases. The costal element of thoracic 1, 2 and the lower vertebrae gets enlarged to form the ribs. So the costal element of the C7 vertebra also gets tempted to form an enlargement of its costal element and form a cervical rib. It may be unilateral or it may be bilateral, or it may be small, only the bony part, or it may be big enough and a fibrous band may join the bony element to the upper part of the manubrium sterni. Since the thoracic inlet becomes higher in these cases, the subclavian artery and especially the lower trunk of brachial plexus have to be arched and come over to the axilla. So in this case, there is arching of the lower segment of the lower trunk of brachial plexus formed by C8 and T1 segment, and this arching may stretch on the lower trunk of brachial plexus. Even subclavian artery may be involved, so that there may be nervous symptoms and there may be vascular symptoms. The nervous symptoms one can see in relation to the hand. The small part is showing the normal hand, and the affected hand is showing that it is a monkey-like hand or a ape-like hand. The muscles which are forming the thenar eminence, the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis, which is a thicker muscle, get paralyzed, and the movement of the thumb are severely affected. The thumb is most important for opposing the fingers, for holding on to the things, so that particular part will not be possible if these muscles are paralyzed. Now the other variations or other abnormalities are the slipped disc. There is an intervertebral disc, which is a fibrocartilage which lies between the bodies of the vertebra. This intervertebral disc comprises of a central notochord part or nucleus pulposus. This nucleus pulposus is a remnant of notochord, and the outer is the fibrocartilage. This nucleus pulposus starts herniating during third decade of life, and if it herniates posterolaterally, the nerve which is passing from the intervertebral foramen may get affected, causing weakness of the muscles which are supplied by this particular nerve. The notochord, the nucleus pulposus, is a remnant of the notochord and is a jelly-like material. Now, the spondylitis, the intervertebral disc gets degenerated, or the vertebral bodies may get degenerated, so there are bony changes in the vertebra. The bony changes involve, there is deformation of the intervertebral foramen. This intervertebral foramen actually transmits too many structures. There is the ventral root of the spine, ventral root of the spinal nerve, dorsal root of the spinal nerve, the trunk of the spinal nerve, the ventral ramus, and the dorsal ramus. 5 of these nerves, the spinal artery and the spinal vein. All these 7 structures are crowded together in this intervertebral foramen. So any deformation of this intervertebral foramen may cause paralysis or weakness of the muscles which that particular nerve will supply. This is spondylitis. Sometimes these vertebrae may have very, very small intervertebral disc, or intervertebral disc may be virtually absent. That will give rise to a condition which is known as block vertebra or Kippel-Field syndrome. In that syndrome, again, the intervertebral foramen will be very small, and there is radiating pain in the neck and along the upper limb. Now we come to a condition which is known as the tuberculosis of the cervical spine. The tuberculosis in our country is very, very rampant. The nerve roots are coming from the intervertebral foramen. They form the roots and the trunks, and they are enclosed in an axillary sheath with the subaxillary artery. The sheath is thick around the artery and thin around the axillary vein. As this sheath passes down, the cold axis of the vertebra also passes in the upper part of the upper part of the axillary sheath, or it may pass down in the lower part. In the same in the same way, there may be aneurysm of the axillary artery. This aneurysm of the axillary artery is a weakness of the wall of the artery, and this may press upon any of the roots or trunks or cords or branches, and may cause weakness of the muscles and cause loss of sensation of the respective nerves. As far as the nerves are concerned, the last one is the winging of the scapula, which is produced by paralysis of nerve to the serratus anterior. This is known as nerve to serratus anterior, or it is known as long thoracic nerve. This nerve, if it gets pressed, and if we do the protraction of the scapula, there is medial border of the scapula cannot be supported by the paralyzed serratus anterior muscle, and this gives rise to winging of the scapula. In this particular case, the right scapula is showing a winging position. Then there are the brachial. The brachial plexus can be blocked by giving various anesthetic agents, and in this case, the person does not have to be given general anesthesia. A local anesthesia which patient can tolerate will be good for doing the surgeries in the upper limb. These approaches can be interscalene between the scalenus anterior and the scalenus medius, or it can be supraclavicular above the clavicle in the posterior triangle of neck, or infraclavicular or axillary. The only side effect of this is the development of the HORNER'S syndrome, which I have told you. It comprises of 4 parts: the ptosis, meiosis, anhydrosis, and enophthalmos. And if one is careful, and lot of anesthetists are getting surgery done on the upper limb and lower limb by the blocks of the brachial plexus or block of the lumbosacral plexus. Some of these nerves may also be affected by heavy bags which children carry. The musculocutaneous nerve or the radial nerve can be affected by those. Thank you.